Good afternoon, ladies and gentlemen. My name is Nicolas Derval. I'm from the Bordeaux University, and today it's my pleasure to give you our experience in persistent AF ablation using ethanol infusion of the vein of Marshall. So this is my disclosure. So as you know, since several years in Bordeaux, our approach for persistent AF ablation was the stepwise ablation. The stepwise, in fact, is a combination of different steps. The first step for everyone is a PV isolation. Then we combine substrate-based ablation or linear lesion. That strategy was described initially in 2006. We changed it a little bit over time, but overall, we had some very interesting results, especially acutely with a high rate of termination. And short to mid-term follow-up was also quite interesting. However, the more long-term follow-up showed some limitation and was a little more deceptive. And we also identified some limitation into that strategy that we will briefly go over. And this is why we finally decide to move to something different that I'm gonna present with you. So one of the main problems of that strategy is the step of substrate-based ablation, because it is difficult to identify what are the true driver of atrial fibrillation. We have used over time different strategy to identify this driver, looking at the EGM characteristics, using some more recent mapping technology like body surface mapping or other technology. But the global endpoint of all this strategy was the restoration of sinus rhythm. This was really the main endpoint that we wanted to achieve. And this was some sort of validating our approach. So common endpoint, but also common consequences. And the common consequence of that sort of approach, only driven by AF termination, is that you create a patchy lesion set because you ablate in different places of the left atria that will generate scar and border zone almost everywhere. The first consequence also of that is impairment of the atrial physiology, and we have really identified that by looking at patients with MRI or echocardiography, and we found that in this patient the contractile function was impaired, but probably also the diastolic function, and MRI identified large area of scar. So impairment of atrial physiology because of that patchy lesion set, but also creation of a complex substrate that was really favorable for subsequent atrial tachycardia. And this was also a very frequent problem that we had using that strategy, is a multiple atrial tachycardia defined by scar, but also by anatomy. And we have really worked a lot on that post-AF atrial tachycardia. And in most of these patients, we have realized that this tachy was really intricate, and one tachy was often leading to another one, making the day in the lab feel very long. You could have patient coming with a focal, then having a macro, then what we thought was a localized. So you see a very large and consequent number of atrial tachycardia. But finally, what we have also realized is at the end of that very long and multi-stage ablation process, in 97% of the patient, we realized that this patient required left linear lesion to be treated, meaning roof and mitral. So very complex presentation, but finally, most of the case was related to macro reentry, in fact. And this took us a bit of time, and this was quite difficult to really understand, because this tachy, they don't have a very simple presentation because the substrate is complex, and even in typical circuit like perimitral or roof, Finally, the circuit itself is very atypical, using tortuous route into the left atria because of the scar. In many situations, these tachy are multiple. There are 2 or 3 tachy coexisting together, making the mapping, of course, more complicated. And this is something very important. In a large percentage of the patient, these tachy were using epicardial structure. That makes this tachy very difficult to treat, because by using epicardial structure, there was some protected isthmus that we could not reach from endo. And this is especially true with the Marshall bundle that was very important into that scenario for perimitral. You can see in that little tachy that the circuit is certainly using an epicardial bypass here. And so this was a very important step for us, is to the work of Miguel Valderrabano that really pioneered this era, and that when he reported for the first time the possibility of doing ethanol infusion in the vein of Marshall to treat it, because this structure is described as being insulated in fat, and that makes it totally protected from radiofrequency. So you need to have something different to treat it. And ethanol infusion proved to be very efficient and also safe. And so all this experience over the years and all this new tool makes us rethink at what would be an ideal ablation strategy. I think an ideal ablation strategy is a strategy that is targeting from the beginning the anatomical structure that favors AF. Of course, the pulmonary vein, our anatomical structure that is very important in the atrial fibrillation, but also probably the Marshall vein. There's a lot of reports that say that the Marshall network is also implicated in reentry. It would be a strategy that respects atrial physiology. We have seen before that a strategy only based on EGM consideration, only only willing to terminate AF has some pitfalls and often is associated with impairment of left atrial function. So I think that strategy should take into account the physiology and should prevent, of course, the main atrial tachycardia, because we have also seen that these tachy are very important to be treated. So this is how we decide to do that different approach that we call the Marshall Plan strategy. So it's a strategy that wants to do all these different steps. To do that, first you need to create the best lesion you can do, because it is important to have line and PV that are really complete. And for that we use all the new technologies that is available. Systematic use of contact catheter, cartomapping, automatic annotation, use of very strong criteria of stability and force during each burn, using high power short duration, using systematically a deflectable sheath to improve the lesion, but also to create systematically chemical ablation, especially for the mitral line, using ethanol infusion systematically. And I think these two parts are really important if you want to have a lesion set that is complete in this patient. So I will report the result from the first 75 patients we did using that approach. So the first step is to treat the Marshall structure. So in that initial series, we could do ethanol infusion in more than 90% of the case, which is a very interesting result. We had only 6 patients with failure. In one patient, we misinterpreted the venography and we ethanolized the left atrial appendage by mistake. In 2 patients, we had a very proximal dissection of the vein. In 3 patients, we could not find the vein of Marshall. So this is an example of one patient. You can see that we use an approach from the femoral vein with a deflectable sheath, a Lima catheter, and we inject through the over-the-wire balloon the vein of Marshall here. You can see that relatively complex anatomy. Then this is the contrast injection after the first 3 cc of ethanol. You can see that you start to have tissular tattoo because the capillary is destroyed by ethanol, and so the contrast will then fuse into the tissue. It is totally normal. And after 10 cc of ethanol, this is our usual dose of ethanol, you can see same tissular tattoo, which reflects a good procedure. Second step is the PV isolation. That had no problem. Of note, the left PV isolation is shorter than the right PV because of the effect of ethanol. And then the line, the mitral line, you can note the high percentage of acute block, which is something we have never seen in the past, with more than 90% of the patients with complete mitral line block at the first procedure. And that's really interesting, of course. It is also important to understand that ethanol is not going to make all the job for the mitral. In most of the case, you need to have complementary ablation endocardially next to the mitral ring, but also in the coronary sinus on the atrial side in most of the case of the coronary sinus. And after doing all this stage ablation of the left atria, I think it is really nice to see how the physiology of the left atria is respected. This is an activation map that is recorded before ablation in a patient. You can see the right to left conduction through the Bachmann, but also the collision of the wave on the posterior wall of the left atria. Voilà, it's going to move, and you can see. So this is before any ablation in sinus rhythm. Okay, and this is the same patient after ablation with vein of Marshall, PV, and line complete. And you can see that the right to left conduction is totally respected. The left atrial wall is activated very normally. The left atrial appendage is also respected. And you can see in the posterior wall the collision on the roof and the mitral will make our almost at site of natural collision, which again, I think respect totally the left atrial physiology. And this translates into a conservation of atrial function with A wave of almost 60 in this patient. Looking at the clinical result at 12 months for this patient, this is Kaplan-Meier with patient with single procedure without antiarrhythmic, and here with 1 or 2 procedure. So you can appreciate this result. Single procedure of antiarrhythmics at 12 months, 72% success rate. If you consider only patients that had a successful vein of Marshall ethanol infusion at the first procedure, then this number reach almost 80% at 1 year without antiarrhythmics. And if you accept 1 redo procedure, that would be a repetition of the first procedure because we don't add any other line of ablation in redo procedure, then you almost reach 90% of success. So in conclusion, ladies and gentlemen, I would like to say that our previous experience with extensive AF ablation based on café elimination has shown some important pitfalls. We propose now a new ablation strategy that takes into account the crucial anatomic part of the left atria. The Marshall plan targets the native atrial structures that are involved in the fibrillatory process and post-ablation reentry. And through a clear succession of visible endpoints, we think that this lesion set respect atrial physiology. In this prospective monocentric consecutive series of patients, we prove that this strategy was feasible, was safe, and was efficient with more than 70% of success rate at 12 months without any antiarrhythmic drugs. Thank you for your attention.